potential for extreme highs and lows, particularly in the obstetric setting, as the mother has a strong bond and emotional ties to the fetus, and this draws the sonographer into a closeness and perceived moral obligation to the mother. There are variations in the sonographer's role in communicating, just as I have said, but unfortunately, there is a lack of understanding, there is a lack of recognition, there is a lack of support of sonographers by the other professionals working within obstetrics, especially the radiologists, the sonologists, the referring doctors, the obstetricians, and the midwives on the sonographer role in communicating with patients. And then there are also no models of communication. There are no set protocols and policies in communication with patients. Sonography or obstetric ultrasound is very unique, as we'll see later during the presentation. So sonographers face communication barriers to patients and a risk of compassion fatigue with every adverse finding due to suppressing empathy and compassion to the patient after the breaking of bad news. And this is cited by Johnson et al. From a study that was done in 2018. Okay, so the background to obstetric ultrasound. Routine ultrasound is considered as a social event by the majority of expectant women with no expectation or anticipation of negative results. Experience of a scan, of an obstetric ultrasound scan has a profound and unforgettable impact on the mother, irrespective of the diagnosis. Patients view ultrasound as a social event to see the baby and the baby's gender so that they plan on shopping, colors, and the necessary decoration. Prenatal ultrasound has become a social ritual, especially in Western culture, and it's considered as a chance to see and meet the baby for the first time and to take pictures and share with friends and family and even strangers. That's why even when the patients attend, we see that social aspect of obstetric ultrasound, and we see the baby reveals and all. There is not much that is emphasized on the clinical aspect of obstetric ultrasound scanning. So ultrasound induces anxiety in expectant patients, which develops into physical trauma after bad news, regardless of the state of the pregnancy. Bad news, as we've said, is often unexpected and uncontrollable, and it results in feelings of loss and bereavement. Real-time scanning robs sonographers of the vital period of preparation of disclosure of results and the general guidelines that are being used at the moment for breaking bad news are borrowed from SPIKES protocol developed from cancer research, and that calls for an advanced preparation and booking of the patient for disclosure of results, usually common in medicine. So the doctors and nurses usually have a period of preparation, and the patient gets their results after an appointment. But now with sonographers, real-time scanning, you get your findings and you have to break them to the patient there and there. So as we said, there are a few evidence-based guidelines available to assist sonographers in this disclosure process. SPIKES has been dominant, but it does not suit sonography. So the UK has developed the first guidelines, consensus guidelines. They're in the process of going on to make dedicated obstetric scanning communication standard in breaking bad news. Okay, so communicating of bad news to patients is determined by the sonographer's ethical, cultural, psychological, and legal environment in this task. Issues to do with autonomy, issues to do with capabilities of radiographers as sonographers, as to the communication capabilities after disclosure, and also the scope of practice of most sonographers is a bit restrictive to communication, and communication is usually left as a preserve for the referring doctor or the obstetrician. So in contrast to other areas of clinical sonography, obstetric ultrasound has some unique characteristics when it comes to effective communication. The majority of obstetric patients, as we have said, are expecting good news, irrespective of the circumstances surrounding their pregnancies. And the sonographer and the patient, in most cases, are meeting for the first time and hence are total strangers to each other. The patient, in most cases, is accompanied by family members and significant relations who may hinder or enhance effective communication. So both the patient and their family and the sonographer are embarking on a voyage of discovery, especially if the scan is the first one in the pregnancy. So this also complicates the breaking of bad news or the communication of adverse findings in case there are any. So sonographers are in a conflicted position as they are not sometimes the reporting practitioner. In some countries, the sonographer does the imaging and the radiologist or sonologist is the one who makes the report from that and does the communication. So this non-disclosure becomes very difficult and stressful because patients expect to know the results of their scan immediately. When you are doing the scan, they'll ask you, is the baby okay? Can you show me the baby? So that puts the obstetric sonographers in a dilemma. Okay. The patients that we are attending to are very informed about pregnancy and childbearing. They research so much, they have access to internet. So even when they come for scan, they are loaded with information. And unfortunately, we don't even know how much information they are loaded with. So these patients have changed the working parameters and expectations of the sonographer role. So because of that, best outcomes for both the patient and the sonographer is desirable. And this is fulfilled by effective communication. So there are potentially moral and ethical decisions imposed on the sonographer about communicating results, which are peculiar to obstetrics due to the psychological and emotional attachment the mother has to the unborn child. Research shows that the act of showing the baby on the screen to the mother is very important in bonding. So the sonographer-patient interaction is in an emotional environment. It has the potential for extremes, highs and lows, and the mother is already developing the strong bond and the emotional ties to the fetus that draws the sonographer into that closeness, and it's perceived as a moral obligation to the mother. So the sonographer has a role to deliver a patient-centered approach, which explicitly centers on the needs of the individual patient, and at the same time, that sonographer is bound by their scope of practice and is bound by ethics and is bound by protocols, departmental or organizational or country policies and protocols. So following an adverse pregnancy outcome, some patients are consumed with intense grief and may go through a series of emotions, which include denial, anger, bargaining, depression, and acceptance. So grief is defined as a process of experiencing psychological, behavioral, social, and physical reactions to loss. It is dependent on an individual unique perception of loss and does not need any social recognition or validation by others. Grief is a very personal aspect and it's acknowledged by the beholder. What may be seen as an adverse finding by the sonographer may not be an adverse finding to the patient themselves, or what the patient or what the sonographer perceives as a good finding in ultrasound may be perceived by the patient as a bad finding. Sometimes pregnancy itself is a bad finding to the patient, especially the unexpected pregnancies. So each patient's situation is different and their reactions to any news about the pregnancy are difficult to gauge in advance. Generally, women are not prepared for bad news about the health of their unborn child. So it is crucial that prior to the examination, women are provided with objective and balanced information about ultrasound screening, both in terms of its potential virtues and its limitations. So bad news and in obstetrics may be the other types of factors that can be considered as bad news: twin pregnancy or multiple pregnancy, intrauterine fetal demise, sometimes the wrong sex and undesirable fetal gender may also be a bad news to a patient. Ectopic pregnancy may be also considered to be a bad news. And then there are some bad findings to sonographers, like the disappearing twin syndrome, which may be good for a patient since if they have some economic hardships. So it may be a relief to them to have one child instead of the multiple children that they may have been expecting. So there are some different types of grief that we can have with our patients. There is anticipatory grief, there is disenfranchised grief, and there is complicated grief. Anticipatory grief occurs when the patient is already having some bad symptoms in their pregnancy, like when they're draining amniotic fluid, or when they are bleeding in pregnancy, or when they are not perceiving any fetal movement. They come anticipating that there may be something wrong with the baby. And then is the second type of grief, which is disenfranchised grief. This type of grief may not be accepted by other people as grief, but may be valued by the patient themselves. So the loss is devalued, stigmatized, or cannot openly mourned. Some cultures may minimize the loss of an unborn baby as something that's not worth grieving over. This is very common with miscarriages or termination of pregnancy. You may find the mother is very emotional and grieving, but other people feel there is really no need to grieve because they don't have a personal relationship with the fetus yet. And then we have also the complicated type of grief, which arises from the loss of a highly anticipated and precious pregnancy. There is denial and there is extreme bereavement with this type of patients. Some of these patients may actually seek second, third, and fourth opinions in different ultrasound departments, and some may still insist on perceiving fetal movement, even if they've been told that the patient, the fetus has been dead. Sometimes you may say that the Spalding sign is there or the fetus is macerated. The patient may still tell you that they are feeling fetal movement as you are doing the scan. So the women also go through 5 different stages of grief, which are stated here. There's denial, there's anger, there's bargaining, there's depression, and there's acceptance. But we may in ultrasound, we may just have denial, anger, and bargaining, and maybe depression. Acceptance usually comes at a later stage. So the women cope with the diagnosis of fetal abnormality by moving through 4 temporal stages. They assume the normal, and then they have shock, and then they gain meaning, and then there's rebuilding. So assuming shock happens when we disclose, they assume normal first before it really sinks in, before they understand the news that you are breaking to them. And when it sinks, they get shocked. And then meaning comes when you have to explain to the patient, and then the rebuilding comes from more information that is provided by the sonographer and the support team after the interaction with the sonographer. So interaction with the sonographer is important during the brief period of shock, as the type of information and the manner in which it is given affects a woman's ability to cope in the future. Grief management. Grieving is a unique and highly individual experience. There is no right or wrong way to grieve. How a patient grieves depends on many factors, and it includes personality, coping style, life experience, faith, and significance of the loss. Grief can trigger many different and unexpected emotions. With some patients, they will be numb and they may not even show any reaction to the grief. You can't perceive how they are exactly feeling. But some patients get so emotional to a point of crying or throwing themselves and rolling on the floor. So we need policy reform. Oh, sorry about that. Policy reform include improved clarity and standardized protocols are needed to improve practice guidelines for sonographers for communicating adverse outcomes to expectant mothers, so that it's not a personal choice and it's not according to the sonographer discretion, but all patients are afforded justice. If communication is not given to any patient, then communication is not given to all patients, such that we avoid the circumstances where you give some patients and you give others. So sensitive bereavement care, staff education, provision of appropriate facilities, and an institution-wide approach to standardized care for bereaved parents is paramount. There should be facilities for privacy so that the news can be communicated to the patient in privacy. And there should be a facility for aftercare of that patient, rendering psychological support, sometimes just being there for the patient. And if the patient is on their own, there should be a provision of maybe getting a relative or a close significant other who can come and collect them and take them to the doctor for further management. So the care that patients receive at the time of perinatal bereavement can shape their entire grieving processes. Negative experience can contribute to complicated grief, and they may associate all ultrasounds that they may even have in the future, or that they anticipate in the future that they may have a negative outcome. So the sensitivity of communication of adverse findings broken to patients is remembered as part of the overall memory of experience, and it has a profound and lasting impact on parents. Compassionate and empathic communication by the sonographer is essential. The language that we used, the terms that we used, and how, where, and when the news is broken matters. We shouldn't break the news when the patient is still sleeping on the bed with their lower abdomen exposed, but that's why it is essential that we have a room in privacy where, after dressing up, you can go and disclose whatever bad findings that you found or that you have from the scan. So the environment matters, and the communication should also be open, sensitive, and honest. But we should not communicate beyond our limitations. Communicate what you are sure of and leave the rest of management to the referring clinician, because as a sonographer, it is not our path on how the complications will be managed. So the sonographer roles and responsibilities in grief management, there is a role to the patient, and there is a role to the self and to the profession. So due to evolution in patient-centered care and patient involvement pathways, global sonographer professional dynamics, and global migration, sonographers should prepare for the role of primary communication of bad and difficult news to patients during obstetric ultrasound by pioneering policy development and standardization of obstetric communication practice. The sonographer has a role to deliver a patient-centered approach which explicitly centers on the needs of the individual patient. And research that has been done on the needs and preferences of patients in obstetric ultrasound show that the patients prefer that the sonographer shows them and discloses their findings to them. So with patient satisfaction and patient-centered approach in medicine, we also have a role to evolve and assume that role of communicating to the patient. We also have a role of formulation of clear and concise departmental protocols, which are initiated by the sonographers themselves. And then there should also be training in obstetric sonography specific news communication so that we have an evidence-based and interprofessional approach to develop departmental policy and national policy in recognition and support of this communication role. And we also need multidisciplinary teams and interprofessional collaborations in obstetrics in all health sectors to promote a different model of clinical relationship based on shared decision-making and patient-centered care. And this should be uniform in both private and public sector so that we offer uniform obstetric care, which is seamless, which is continuous, and strive towards patient satisfaction. The sonographer also has a role to provide emotional support to the woman and consider that as an opportunity to share their own humanity. When a patient is grieving, we should show that we care, we have compassion with them. And although during the immediate first phase, the shock can prevent the patient from comprehending the information given, empathy and sympathy can help to turn these difficult moments into a time of communication and change perceptions on the issue. It's a time to explain in different ways so that the patient understands what you are talking about. And it's a time to show the patient that there is still some light at the end of the tunnel, and that adverse finding is not unique to them. And as a sonographer, you may have experienced the same adverse findings with the same patient, and sometimes you can refer that patient to other. You can tell the patient that there is a support group, especially like for mothers with children or children with Down syndrome. There are some support groups for that. And then the prognosis of the findings, you should, as a sonographer, I feel it should be left to the referring clinician. But if there are some cases that we can just mention that, but there are some children who survive with this condition. Some of them survive to adulthood. Some of them maybe survive to teenage. So we should also have a cultural awareness, cultural sensitivity, and cultural competence so that we can deal with patients without using our own culture as judgment to patient values and norms. So we also need to foster patient health literacy. Actually, when you have a patient who's coming for a scan, it's the time to educate them that a scan is a medical test. It's not a social event, and letting them know that there may be bad findings in a scan. And as much as there may be bad findings, there are some findings that are uncertain on ultrasound. So there is also need for therapeutic communication in the patient-provider relationship in interpersonal exchange using verbal and non-verbal messages. This communication expresses support, it provides information and feedback, and it also corrects distortions and provides hope to the patient. As sonographers, we have to be really wary to the verbal and non-verbal communications that we are giving to our patients. As we are scanning, the patients are observing us and searching for any cues to the abnormality or to the normality of their children. So if they see prolonged stares, or they see a frown, or they see they notice nodding and some other body movement, they may pick that there is something that the sonographer has picked. Sometimes they even sense the change in mood of the sonographer. And the communication that we give verbally and non-verbally should be the same. So after discovering the adverse findings, sonographers should be able to readily facilitate contacting the relevant specialist with a goal of providing holistic continuity of care, and there is referral and support system for the patient. In as much as you refer the patient back to the doctor, when you feel your capabilities in diagnosis of the adverse findings that you have seen on the patient are limited, you can refer to a specialist sonographer in obstetrics, or you can refer to fetal medicine. And then for continuity of care, you refer to the doctor, and if need be, you can refer to counseling department, or some departments or some institutions of counseling. So before you refer the patient back to the clinician, you can have a brief counseling session so that the patient can be calmed before they go back to the doctor. And if there are pamphlets for support system for patients, they can be distributed to patients in the department and our hospitals. And we also have the role, as I've said, to patient education and health literacy. For role to self and to the profession, sonographers have the responsibility of spearheading policy reform and collaborative approach by professional bodies to break down the barriers of interprofessional tensions which are there in obstetric ultrasonography. The professions that work within obstetrics are not accepting in many countries of the role of the sonographer in communication of findings to patients. So policy reform will break down the interprofessional tensions and the turf wars, and it will help in improving the acceptance of a sonographer's role in obstetric communication. So continuous professional development and effective communications training allows providers to become aware of their personal attitudes and emotional reactions when breaking bad news. Ethical practice in breaking bad news follows the principles of beneficence and maleficence, so it also avoids aggravation of traumatic situations and grieving patients. We should also adopt deliberate practice in the development and refining of essential sonography communication skills. With deliberate practice, it's intentional, and sonographers may decide that all sonographers will have to go for communications training or some counseling training, so that those sonographers who perform obstetric ultrasound may gain expert skills in communication. Sonographers also have a role for effective and efficient communication, and like I referred to verbal and non-verbal communication, that they should be consistent. And also, sonographers should provide information in pregnancy. It should involve the physiological, behavioral, social, cultural, and biomedical components. And we should embody the value and cultural knowledge as well as biomedical evidence. And we should remember that this care is tailored to the needs of the particular woman at the specific time of her pregnancy. The needs usually differ. The grieving is different depending on the stage of pregnancy. Third trimester usually has the worst grieving from expectant patients. So the information should be given in a manner and through a medium that is understandable and accessible to the woman. As sonographers, we also need to practice professional judgment and practice patient-centered communication. This identifies patient needs with consideration to their cultural, spiritual, religious beliefs and practices. We also need emotional intelligence, which is the awareness and management of emotions in self and others. We should be able to recognize reactions in patients. We should be able to recognize symptoms in patients, and we should be able to recognize our own symptoms as sonographers, such that you can handle the patient and handle the examination. If you have a very emotional sonographer, maybe by the time they finish their exam, they're already emotional and crying. And if you have an emotional sonographer and an emotional patient, then it does not help. So the sonographer-patient interaction, in the sonographer-patient interaction, emotional intelligence would also help avert compassion fatigue for sonographers, because sonographers are exposed to so much grief and agony in the suffering of their patient. They take that grief and internalize it to themselves, and they end up suffering compassion fatigue, which also needs to be mitigated. Sonographers have to know and identify the effects, or they have to know and identify compassion fatigue, so that they care for themselves and care for other sonographers. Policy reform, improved clarity and standardized protocol are needed to improve practice guidelines for sonographers in communicating adverse outcomes to an expectant mother. We need sensitive bereavement care, staff education, provision of appropriate facilities, and a hospital-wide approach to standardized care for bereaved patients. Okay, like we have said, that a compassionate and informative method of breaking bad news is particular to the type of news, the anxiety level of the patient, comfort level of the sonographer, and the resources that are available to the women. Departmental policies are a responsibility of sonographers, so that their formulation is our responsibility. Where we don't have sonographer, where we don't have the protocol, sonographers have that role to come up with the policies and implement policies and revise the policies and keep them up to date. As we talked about deliberate practice is focused on goal-oriented activities that are designed to improve a complex skill. And in this case, communication of adverse findings is the difficult skill. So activities are designed to improve communication and influence the development of expert performance beyond the individual differences that we have as sonographers. So deliberate practice is intentional, and it's aimed at achieving a level of expertise beyond every individual's proficiency. Sonographers should be cognizant with the role of continuing professional development and deliberate practice in providing advancement to the level of proficiency and the pathway towards expert practice in bad and difficult news communication with their expectant patients. As I said, that it is important to have a multidisciplinary patient care model following diagnosis of bad news, which accounts for input of healthcare providers to offer psychological and clinical support. And here we can include all the professions who work in obstetric medicine. In Zimbabwe, our interprofessional collaborations are still poor, and sonographers are limited to refer patients by their code of practice and by the referring clinicians themselves. So I don't know how other sonographers are maneuvering around it in their departments. So in some countries, there are some sonographer support groups for compassion fatigue, because it has been realized that it is a big problem, especially in obstetrics. And it's worse with fetal medicine, where all the patients have some adverse findings. So there is need for formal support and self-care management for sonographers. So when sonographers share clinical experiences, feelings, and stories with trusted colleagues, painful experiences can be channeled into a greater understanding of the empathy and compassion needed to care for themselves, their colleagues, and their patients. Let's be our brothers and sisters keepers as sonographers, and have unity of purpose in caring for each other as well as our patients. In conclusion, there is need for a formulation of ultrasound specific guidelines through research to understand the sonographer's position. The small gains in research for each small department, for each small organization, for each country may be the big gains for all sonographers worldwide, as we may have a policy that is recognized and international. So in the United Kingdom, like I said, they are already in the process, and once they've started, because they've started the ball rolling, as sonographers, we can also look at what they have, and we can also borrow from that and personalize it to our own circumstances. So there is need of generating detailed consensus guidelines that regard best practice for news delivery in obstetric ultrasound. There is considerable evolution in role development and role extension of the sonographer, both globally and locally, especially in obstetrics, and it has been met with resistance. It was the same thing in the UK. It was met with resistance, even though they've managed to come over that hurdle. So the tough conflict and resistance from other professionals of medicine are common. So there is a need for clear and defined scope of practice and communication protocols for obstetric sonographers. And we also need professional recognition of the extended role of the patient sonographer oral communication by all of the professionals involved in obstetric care. Professionals working in medicine can work in synergy and work as one, all in benefit for our patients. So in closing, I was thinking if sonographers may be interested in creating a sonographer support group to listen and to provide positive coaching to one another, and maybe establish a radiology without borders shuttering maybe once a week. Then we may have an annual multidisciplinary communication workshop, which can be online, in breaking bad news. And then there can also be a dedicated multidisciplinary bereavement support team, which should have fair sonographer representation in our different countries, in institutions and provinces. And as sonographers, I think we should also take the responsibility of maybe having our own African website, sonography website, for patient education and health literacy that is interactive, that is updated, and different people can at different times be in charge of managing the website or the social media account, so that we also get to educate patients, and we also get to have our professional recognition that we yearn for as sonographers. So these are the references that I used for my presentation. Thank you.
So much, Samukeliso, for that amazing presentation. Well, it was really good, and I'm hoping the people that have logged in have learned a lot. It's time for the question and answer session and any contributions. So if you have something to contribute, or if you have a question, just raise your hand, and Madam Trines is going to help with the question and answer session.